Well, thanks. Good morning for joining us this morning. Well, I know we have a lot of questions to ask to Dr. King. I want to thank you for your time this morning. Obviously, being our Independent Day, people have things to do. In the interest of time, I want to call this meeting to order. Some of you not know, Orlando, what the main thing to accomplish this morning is to get Dr. King to do a presentation on the vaccine, for us to at least ask some of those significant questions, which is critically important that we want to know about. And of course, and the way forward and the interest of our staff. I think for the interest of time as well, let's try and keep the questions to the end when Dr. King does his presentation. And I think from there we can go forward. I think, at the end of the day, we all know that the vaccine is people's perception of the passport to the way forward. The many conversations I've had with individuals are been very mixed, but mainly from the local community saying they don't feel like they want to take, their staff want to be forced to take it. I did identify to one member of the team saying that, well, it's not about forcing, it's about giving you information so you can have a informed decision. You know what I'm saying? But personally speaking, I can see St. Lucia as a tourist destination, making that part of the passport to come to the Caribbean, just as my personal opinion. But anyway, Dr. King, I want to hand it over to you. Thank you so much. And I have my friend Faye there, my communication manager. Just need to get names, information, who's on the call, so we can really, put some minutes together on this meeting.
So good day to all in attendance. It is indeed a beautiful Monday. Director Orlando Satchell, with due diligence to the independent restaurants, food and beverage sector, welcomes you to Dr. Stephen King's COVID-19 Q&A presentation. Some of you restaurateurs may have pertinent questions in reference to this vaccine. And so Director Satchell, with due responsibility to his sector, is facilitating this session to address your concerns. He has just given a brief introduction, and now Dr. King will present.
So, thank you for taking your time out to listen to me today. I hope that it's worthwhile and we progress. What the presentation I'm doing is really in two parts. The first part actually looks at the COVID-19 disease itself, and various, I think, important facts about that, the COVID-19. And then we talk about the vaccine itself, and we also drill down to actually St. Lucia and some of the St. Lucian issues with regards to the vaccine and the plans that I have been able to get privy to from the Ministry of Health, that is. And the first thing I wanted to say, and why this COVID-19 disease is so disturbing for us and disturbing for the world, is because of its unpredictable nature. The thing about this particular virus is that it has such a broad spectrum of behavior in our bodies. There are some people that have no symptoms at all, what we call asymptomatic. There's some people that have very mild symptoms. In fact, the majority of people have either actually have mild symptoms or no symptoms. That's the majority, over 80%. And that gives you a certain sense of complacency, because a lot of people say, well, yay, this is, as you've heard in the various chats, this is not a bad disease. It's like a basic flu. What's the problem with it? Why is everybody freaked out? But unfortunately, there are about 10% of people who will have severe or critical disease, and anywhere between 1 to 2.5% of people will die. And who these people are is not well known. Now, we've heard that if you have a comorbid condition, if you have diabetes or hypertension, yes. If you have other chronic non-communicable diseases, yes. So we know if you're an older person over the age of 65, and of course, over the age of 75, even more so. So yes, these are risk factors that we know. But there are others. And recent studies are showing that there's a genetic predisposition to having a bad course with COVID-19. Because there's certain people with certain genetic makeups will have a hyperinflammatory response, hypercoagulable, hyperinflammatory response to the virus. And these are the people that get very sick and die. So this is what a diagram of the virus. The important point of this particular slide that I want to focus you on is those blue proteins, those blue spikes. So this, you can see why they call it corona, because it looks like a sun. And those blue spikes look like the rays of the sun, right? So you can look at it in that way. But those spikes are important because those spike proteins are the proteins that interface with our own cells in our body and cause the virus to inject its genetic material into our cells. So these are like a key that opens the lock to our cells for the virus to invade. Also, these spike proteins are the very ones that we use to develop an immune response, a vaccine response. Either natural immunity if you get infected or a vaccine, which is why you will hear every time they talk about the vaccines, they're talking about spike protein, spike protein, spike protein, right? Now, the mutants that are coming up, the more circulation we have of virus and the more cycles the virus goes through, the more likely it is to mutate, that is to change, because all living creatures evolve over time. So the more cycles they have is the more they tend to change. And they tend to change under pressures, under environmental pressures. So what happens, some of the mutants change the spike protein during various cycles. So you'll get, for instance, the UK or the Kent variant, which is more infectious. And indeed, some people say even more deadly, about 70% more infectious, about 30% more deadly, right? And that is because it has mutated its spike protein to be more efficient at getting into our cells. So our cells then get exposed to a higher viral load, so more virus, and therefore more disease. Okay, so that equates to a more severe course. And there are other variants as well, as you know, the Brazilian or South Africa. Now, the other problem with the mutants is because we are raising the vaccines to these spike proteins, you'd appreciate that as a spike protein is mutated and changes, it may also render our immune response that we develop to one mutant to be less effective against the next mutant, since our immune response for the vaccines is really to the spike protein. So that is why you'll find that they're talking about some vaccines not being as efficacious or not as effective against certain mutants. Now, the disease presents with these kinds of symptoms. Headache, very common, very, very common. Dry throat, cough. The dry throat is often sore. So it can be a dry sore throat and a dry cough, occasionally wet, but mostly dry. The shortness of breath is usually a late sign and in the second phase of COVID disease, and usually a bad sign. Some people who are asthmatic do get triggered, their asthma does get triggered, and they will have some shortness of breath because their asthma will be triggered by the initial viral infection. Nausea, vomiting, and diarrhea, reasonably common. About maybe 20% or so of patients will show this, and some people present just like gastroenteritis without even the cough. So some people don't have a lot of respiratory symptoms, but have far more GI symptoms, gastrointestinal symptoms. Then fatigue, muscle, body aches, fever, or chills. These are very common. A lot of people will present with those symptoms. And that is, in fact, why it often gets confused with dengue, because dengue, as you know, presents that same way with fever, body ache. Eye pain was very, very interesting. I find a lot of people with COVID-19 are talking about eye pain. And again, dengue, as you know, also presents with pain behind the eyes. So a lot of doctors even will mix up COVID-19 and dengue, and you'll get in the labs, you'll get people being the differential being dengue versus COVID. Then you also get people with congestion, runny nose, and a rather unique finding of a loss of taste or smell. That is quite relatively unique to COVID-19 for whatever reason. Now, the pathophysiology, or what happens, what we believe, or what we know happens with this virus is not that it targets the neurons itself, but it targets the supportive cells, what we call the sustentacular cells, the supportive cells of the neurons, the cells that that keep the neurons functioning well, that wrap around and support them in their function. These are the cells that get targeted based on the receptors by this virus, and they're the cells that die, and that's what causes the dysfunction of smell and taste. And you'd also appreciate that in the first phases of this viral infection is primarily in the nose and mouth. And that is why you would see that taste and smell are probably the first things that are affected because of that high viral load in the nose and mouth. And the reason that the virus is in the nose and mouth in particular is because this is how this virus spreads itself. It spreads itself by droplets and aerosols. Now, droplets, which you see in red there, are large spit particles, large particles of spit that come out of our mouth when we talk, especially loudly, we sing, or we sneeze, or we cough. Those particles usually will go for about 3 feet or so, and then they will fall down because they're quite heavy. They also, because they're quite plentiful, they have a lot of virus in them. They often will, if they fall on as you cough into your hand, or if you cough onto a surface, you can actually contaminate your hand or your surface. And we believe that that contamination it's possible to get infection from that contamination by people touching your hands, then touching their faces, or touching the surface that you've coughed on and their face, which is why we talk about hand sanitizing and cleaning surfaces, right? Now, you can get aerosols, and the aerosols are much smaller particles. And as you see here, they say less than 5 microns. These particles tend to stay suspended in the air. Now, in the early days, we didn't used to say much about those aerosols, but nowadays we are, because we're saying if you're in closed spaces, poorly ventilated closed spaces, you can get infections through aerosols. We were talking earlier about the restaurants, and we were talking about how our restaurants are open air, and that's good because open air spaces, you're less likely to concentrate aerosols, and you're less likely to get infection from aerosols, right? You see on the other side there about urine and feces, and although virus can be found in urine and feces, however, that has not been identified as a major or a mode of transmission. Okay, so the preventative interventions to date, and just to reiterate them, a lot of people get irritated about this reiteration, but it is very important. They are age-old, true methods. First and foremost, identify and quickly test suspect cases with subsequent isolation of infected individuals. So widespread testing of people, because remember, this virus has a whole spectrum from no symptoms at all to very severe symptoms. So we need widespread testing. And when we pick up somebody that has the virus, we should then test all their contacts, their close contacts. What is a close contact? A close contact is somebody that has been within 6 feet of you without a mask for at least 15 minutes, or alternatively has been in a closed space with you for an extended period of time, a certain portion of the day. So certain workplaces, for instance, these are definitions of close contacts. By doing that, we can rapidly identify infected people, and we can infected people are people that we call they're sick, so we call that isolation. Non-infected people, so contacts who are not infected, they're not sick, we quarantine them. Why? Because this virus can take a while to multiply and get up to infectious levels so we put people in quarantine to identify the people who are now going to develop enough virus to be infectious. So they are potentially infectious, so we quarantine them, okay? Washing hands often with soap and water. In fact, I know there are a couple of lab people on. So one of the points I'm going to say, and you've heard a lot of debate in the public about antigen and PCR and which is good and which is not good and all that kind of stuff. Both tests are good. They work differently and they give us similar information, but also importantly, different information in different ways. So although I'm going to talk about testing, maybe now I'll talk about it because it's relevant right now in this context. Rapid antigen testing is very good to pick up people with a high viral load, with fully formed competent virus, able to infect people. It can pick up people within 20 minutes, so you can swab and test. So within 20 minutes, you can know this is an infectious person, whether they are asymptomatic, so whether they have no symptoms or not. Once they have a high enough viral load of competent virus, because the virus will have the protein, because the antigen picks up the protein coating of the virus. Once they have that, they meet those criteria, they will be picked up antigen positive. These are the people you really want to identify. So that particular test is exceedingly good for mass testing in the general population. It is cheap, easy, fast, can be used out in the field, in a school, in a church, anywhere. It can be used anywhere. So that is the real utility of that test. St. Lucia has been too slow to pick up that test and roll it out, but we are doing that now. I'll talk about the PCR a little bit later because it'll be better when I have the diagrams up. Now, washing hands with soap and water, very important. Soap and water is the most effective way of killing and getting rid of this virus from your hands or from a surface. The virus is a lipid-coated virus, which is a fat-coated virus. And as you know, soap breaks up fat, so it breaks up the viral coat. That's how it kills the virus. Also, if the virus is stuck on your hand, the soap interfaces with that and allows the virus to disengage from your skin and wash off. You need to wash your hands for use soap and water for at least 20 seconds. Today is Independence Day, so you need to sing the first verse of the national anthem twice, I believe it is. Adds up to about 20 seconds. Better yet, just sing the whole national anthem. Be patriotic. The other thing, of course, you can use hand sanitizers. Some of our friends in the communities, I see Rochelle is on, so I'll tease her. Some of the friends in communities called handsome tigers. So the hand sanitizers are alcohol-based. 70% alcohol kills this virus. And that's what the hand sanitizers have, okay? There are various other carriers in them, but basically it's that. Bleach, or 1 in 10 household bleach, is good as well, right? That's a very good thing. The thing about bleach, you have to make it up each day because it loses its potency if you leave it for too long. So we tend to say every 24 hours, make up fresh bleach solution. Wear cloth face masks in public. Masks, there are various types of masks. There are cloth masks, there are surgical masks, there are KN95 masks and N95 masks. The cloth masks, they're very good because they stop your droplets from spewing out from your nose and mouth. They also, if somebody spews droplets at you, they will hit the front of the mask and therefore you'll get less coming into your nose and mouth. Now, your chance of becoming infected is based on the amount of virus you get exposed to and for how long you're exposed to that virus. The third factor, which is a variable, is how susceptible you are to picking up the virus. But the first two are relatively easy to control. The amount of virus we get exposed to and the length of time. And that is why we talk about maintaining social distance greater than 6 feet, maintaining masks at all times, because that will reduce the amount of virus we get exposed to. The other thing is clearly social gatherings where you hobnob with people for too long. You try to minimize your contacts. The time we use is 15 minutes over 24 hours. That's the definition of a close contact, right? Now, the cloth mask is the least safe of masks, but is quite appropriate in the public. It's relatively comfortable to wear. The surgical masks are also comfortable. They're a little bit better than the cloth masks because they tend to be finer mesh. They also have a water-resistant surface, so they tend to whereas a cloth mask, if a droplet hits your cloth mask, it might not be absorbed. It might sort of filter through the mask. It will not filter through the surgical mask, so that's why they're safer. The KN95 mask is a more tightly fitting mask so air cannot easily get around the mask and has to come through the mask, as compared to the surgical or the cloth mask where the air can go around and get into your nose and mouth. So you can suck in virus around the mask. The KN95 fits a bit more tightly on your face and sort of prevents that. So it's safer. It is relatively comfortable to wear. As compared to the N95. The N95 is the most secure mask because it's much more tightly fitting. It has a filter on it, and there are some commercial ones as well, which are, when I say commercial, there's some of those fabricated ones as well with filters. So these filters are supposedly be able to filter at least 95% of all viral particles, and therefore give you much greater protection. The N95 mask, we make sure and use those when we are in aerosolizing environments or closed spaces, because you may remember in closed spaces, it's aerosols now. So anytime there's aerosol exposure, be it medically or in a closed space in the public, the N95 is a better mask to use. People talk about wearing 2 masks. If you're going to wear 2 masks, nothing wrong with that, but you do not, if you put a surgical mask below an N95 or a KN95 mask, you defeat the purpose of the KN95 and N95 because those masks are supposed to fit tightly around your face. If you want to, you put a surgical mask on top of that. If you put a cloth mask with a surgical mask on top, yes, it will offer a certain increased or enhanced protection. So two different masks can give you some protection, greater protection. Practice respiratory etiquette. That's coughing or sneezing into the crook of your arm, turning your head away from people and down to the ground. Disinfect surfaces regularly. I think we understand that. And avoiding crowds, close contacts, and poorly ventilated spaces. And I think I've told you why. Now, this is just a graph to show you the most important one is the very last one at the bottom right, where what it's showing you is a virus. In the blue one is a virus that can infect 4 people from every 1 infected person, and the pink one is a virus that can infect just over 2 people for every 1 person infected. If we wore masks all the time, oh, and by the way, the dotted line is what we call the reproductive number, the RO of 1, which is once you go below 1, that is you have less than 1 person be infected by 1 person, you are now flattening the curve. So that's what that's about. So if all of us were wearing masks all the time, we would actually significantly reduce the amount of infectivity, right? So you can actually 100% masking, or shall we say 95% masking by all of us would actually stop the pandemic. Of course, that's not possible for us, as you'd appreciate. Here is a schematic just showing you how the masks work. And as you can appreciate, very high when there's no masking and low when both the infected person and the non-infected person wears a mask. And there's certain, now in terms of the risk of getting sick and even having severe illness, we spoke earlier, it's related to chronic non-communicable diseases, the amount of virus you get exposed to, and so on. You would appreciate that certain conditions, living conditions and work conditions, and even access to healthcare can affect the course of the illness. First of all, getting infected, or secondly, how badly you do. So, and these are some of the factors here, but you'd appreciate poor people or people who live in poorer living conditions are more susceptible to getting the virus. They also have less access to health services, so their chronic diseases are less well controlled. They have less finance also to control their diseases, and even their protective measures from masking to whatever. So they're therefore going to be at a greater risk of getting the disease and of even dying from the disease, especially in a country like St. Lucia, where a lot of our healthcare is very dependent on how much money you have in your pocket, right? Based on the kind of systems of healthcare that we have. So you can appreciate that the types of people who are at greater risk. I mentioned that it's not just people with chronic non-communicable diseases. And nowadays, or what we found out, and this is just showing you 3 genetic variations that give people a poorer course of with this virus. But I noted recently there are 5 genetic, shall we say, genetic makeups that are making people susceptible. What's happening is with these people, they just have a more exaggerated inflammatory response, and therefore they're more likely to be severe, critical, or die. And they can be young. As a pathologist, I have to show you microscopic slides just so that I can get into my comfort zone. So on the left, you have a lung. And those spaces are the air sacs, what we call the alveoli. Those are the air sacs of the lung. That's where the air comes in, and you get gas exchange at this site. That arrowhead, that green arrowhead, is pointing towards a pink lining that you can see there. That's abnormal. That pink lining should not be there. The lining of the lung should be just the kind of purple little knobbly things, which are the cells. It should be just that thick. When you put this blanket of this is fibrin, by the way. When you put this blanket of fibrin on top of that, gas exchange can't happen, and these people cannot oxygenate, which is why their oxygen levels drop, right? And this fibrin is deposited based on damage to the cells. And when you damage cells, the body responds by pumping out fibrin, which is the beginning of a clot. On the other hand now, or the other side, I should show you, that's an actual clot in a blood vessel. And what this virus does, it damages endothelial cells, which are the lining cells of blood vessels, causes them to die, and therefore causes a clot reaction to form in those blood vessels. So we get multiple clots throughout the body. Now you'd appreciate, because you get multiple clots throughout the body, you can get multiple symptoms. So you can get strokes, you can get heart attacks, you can get kidney failure. You can get necrosis and ischemia of the bowel. You can get all sorts of complications. You can get pulmonary embolism. You can get pulmonary infarction, which is death of lung tissue, based on clots forming, stopping the blood supply to the organ, and therefore that piece of the organ dying. Now, when people tell us, and it does irritate me a little bit to hear people say they didn't die of COVID, they died of their underlying condition. They died of their hypertension, their diabetes, their stroke, or whatever. The truth is, the COVID-19, this virus, is what then caused caused the death by starting a cascade of events. Now, yes, you may be more susceptible to this cascade of events, but if you did not have that virus, you would not have had that cascade, right? The example I use for some people is, since I'm in forensics, imagine I push Orlando down and he hits his head and he gets a clot inside of his brain or around his brain and he dies. Am I not guilty of murder or at least manslaughter for having pushed him? Because if I had not pushed him, he would not have ended up dead. He did not die from the push. He died from the clot around his brain, which squeezed his brain and caused him to die. But it is my push that causes his head to be so. So same thing with COVID. If COVID causes your lungs to be blocked like this and for your oxygenation not to happen, and for you to get what we call a viral pneumonia, or to get clots throughout your body and get a heart attack or a stroke, it was the COVID that caused it. And there are multiple manifestations of COVID-19, what we call outside of the lung. I'm not going to take you through all of them, but suffice it to say that many of these complications can be acute, that is, while you are immediately sick, having been exposed to the virus, but also some of them can persist. So we can get long-term consequences of COVID, which can include cardiomyopathies, neurological problems such as cognitive defects. A colleague of mine here told me that one of her previous consultants in the United Kingdom got COVID. He's a gastroenterologist. He got COVID. After the COVID, the man's cognition had dropped to the point where he had forgotten how to drive. Right? And he had to actually get himself rehabilitated. Eventually, 6 months later, he got back to a certain level of productivity and was able to go back to work. But the point is, she was making the point that let us not underestimate what the long-term consequences of COVID are going to be. I'll point to your endocrine for a minute, just to make a point. Hyperglycemia, diabetic ketoacidosis. We've had a couple of patients die of this already in St. Lucia. And of course, diabetics who get COVID, it can cause a metabolic problem because of how it affects the liver and so on. And that can push them into diabetic ketoacidosis, which is one of the most dreaded complications of diabetes for us doctors. This is what the virus does in our body. So in the first phase, there's a viral response phase where you've just been infected. The virus replicates rapidly in our systems. That goes on for about anywhere between 2 to 3 days before we become symptomatic to about 7 to 10 days after we're symptomatic. So that 2 to 3 week period between being exposed, getting enough virus to then become symptomatic, and then the first week or so. During that time, when we do get sick, we'll have usually mild symptoms, as you see here, okay? Then if we get better, that's beautiful, lovely. However, some of us, and I think we mentioned this, 10% or so are going to go into stage 2 and stage 3. So you go into the pulmonary phase. Now you begin to have infiltrates in your lung. Your lung is beginning to look like what I showed you under the microscope. It's beginning to get that thick coating. Your oxygenation begins to drop, and you can start to go into respiratory failure. Also, at the same time, you can enter into the hyperinflammatory response, where you have multiple cytokines, and that can produce the systemic inflammatory response syndrome and shock, and you can go into multiple organ failure. It can also precipitate multiple clotting throughout your body. We can treat, and we do treat. We treat with anticoagulants for the clotting, and we treat with steroids as dexamethasone for the inflammation, and we treat with oxygen for the low oxygen. That's why you hear people talking about ventilators and high flow. Currently in St. Lucia, from what I understand, we have 9 people on high flow oxygen, which they're critical on high flow, and we have 2 people in ICU on ventilation. Right? In terms of therapy, as I was just talking about, you have antiviral therapy, which is therapy looking at stopping the virus from multiplying. And you can see some of the compounds that we've looked at, including convalescent plasma, hydroxychloroquine, interferon. You may remember that. The Cubans were talking about that. The antiviral drugs, antiretroviral drugs like lopinavir and them, remdesivir you've heard about. Dr. Fauci was big on that. Ivermectin you're hearing about these days. So these are all antivirals. Another antiviral, by the way, is zinc, which is why we often tell people to use zinc, because zinc slows down the viral movement and replication in cells as well. How effective it is, it's debatable, but it does do that. Then we have the immunomodulators. Now that's for the second phase of the disease, and we spoke about that. In terms of testing, you have PCR testing, antigen testing, and antibody testing. Different tests, but you use them in concert because all of them give us valuable information. The PCR picks up nucleic acid, picks up the viral RNA. What that does, it lets us know that you have, it comes up earlier, about 24 hours before the antigen, and it'll last longer, about 2 weeks or so longer than the antigen. So it has a much broader period of positivity. There's also in the PCR, we can also use how rapidly the system can detect the virus to try and decide to get an idea of the viral load, which can also give us an idea of the infectivity, because people are infectious based on the level of viral load. So PCR can give us an indication of infectivity. But you heard me talking about antigen. So what the antigen test is it's a different system, what we call an immunoassay. So it's an immunological test that picks up viral antigen, in this case, usually in the nucleocapsid, which is a very immunogenic protein, and that is indicative of infection. So it is usually positive from about 2 days prior to symptoms to about 7 days after symptoms. So those 9 days is when the antigen is positive. So you'd appreciate PCR is positive longer and antigen is positive for a shorter window, right? Or smaller window. But both of them are very specific, especially some of the antigen tests nowadays. They're almost equivalent to the PCR in terms of their specificity, which means that when they say they're positive, most, depending on the test, some of them are so good that they're as good as PCR to say that you are positive, which is why WHO uses antigen testing by itself in the right context to confirm SARS-CoV without the need for a PCR to confirm. Where the antigen test can fall down, as you could fully understand now, is if what we call the sensitivity, because the PCR is more sensitive because it picks up more people who are positive than the antigen, because the antigen only picks you up when you have a high viral load in that window from 2 days before to 7 days after. Antibody testing is going to become very, very important. It's already important, but it's going to become even more important into the future. Why? This is your body's reaction to. And so it's telling you that this person has been exposed and they've developed an immune response. So after your antigen has gone and your PCR is negative, so antigen negative, PCR negative, your antibody will remain positive. And so long COVID patients, people are presenting to us later, and we want to know if they've had COVID, we're going to have to do the antibody test. Currently, we use it in combination with the antigen. Why? The antibody test usually starts becoming positive by day 10 post-symptoms. So you can use it in concert with the antigen to pick up people who might be antigen negative now. They are sick in the second phase of COVID, but now they have become antibody positive. Because remember, the second phase of COVID is your hyperinflammatory phase, which is where you have antibody. So this is how in medicine we use these various tests. And this is just showing you the gray graph is the PCR positivity, and the red one is the antigen positivity. So that just graphically shows you how it is. This is a CDC antigen testing algorithm. I'm not going to go through all of it. I'm going to take you to the two ends of it. Symptomatic people, antigen positive, they're infected. That's it. No, you don't need to do any other testing. Asymptomatic with no known exposure, antigen negative, they're not infected. So the antigen testing can be used to actually rapidly say that no, you're not infected. Vaccines. There are 4 main types of vaccines. The molecular vaccines, what we call nucleic acid vaccines, viral vector vaccines, inactivated and protein subunit vaccines, okay? The nucleic acid vaccines, you either have DNA, which are really not on the market yet, and mRNA, which are the Moderna and Pfizer that you hear the US talking about in particular, okay? The viral vector vaccines, AztraZeneca is a viral vector vaccine. What that means is that they have taken a chimpanzee vaccine, which doesn't really cause any disease in humans. They've taken out the genetic material of the chimpanzee vaccine, and they've inserted a small amount of they've put a small portion of DNA in there, and that DNA is codes for the spike protein of the of this COVID-19 virus, okay? So this is when they inject us. So let's talk about AstraZeneca, since that's the one we have, the Covishield AstraZeneca. When they inject you with that, that's not a replicating virus, so it will not proliferate in your body. All it will do, it's like giving you a letter. The envelope is the chimpanzee coating, the chimpanzee virus coating, and inside the content of the letter, is the DNA. That goes into your body, and that DNA gets picked up by your cells. In the first instance, the white blood cells will pick it up. They will start to produce spike protein, and they will develop an immune, and they'll cause your body to develop antibodies and T cell, which is the other part of the immune system. They'll cause your body to develop an immune response to that spike protein. Okay, what your body will then do is eliminate the spike protein from your body, including the cells that are expressing the spike protein, okay? The other viral vector vaccine is a Sputnik 5, which is an adenovirus with, again, the spike protein DNA in it. There's an inactivated virus vaccine, which is the Sinovac. That's a Chinese vaccine. What they have done is they've taken the whole COVID-19 virus and they've deactivated it, so it's no longer infectious, but it's complete, and they inject it in you, okay? The other way you can do it, but I don't have the idea on the market yet of that, is you can take out the genetic material and just have the coating of the virus. Then they have the protein subunit vaccine, where what you do is you take the spike protein itself and you join it with another immunogenic substance. The Cubans were using tetanus toxoid and spike protein and injecting that into people to cause an immune reaction. When you decide to use vaccine, use price, the side effects, the logistics, and to a certain extent, logistics includes the ease of administration of the vaccine. That's how we come up with which vaccine is best for us, okay? Also, you'd appreciate when I say logistics. In fact, one other thing that should be put in here is the efficacy. How good is that vaccine, okay? Because that's clearly another factor. So this is what the 6 common, or the 6 that are on the market kind of right now, or about to be on the market. You have the Oxford University AztraZeneca, which is a largely a British developed vaccine, and is being used quite widely in the United Kingdom. It has somewhere in the order of 62 to between 62 and 82. They say 62 to 90 here, but it's usually about 62 to 82% efficacy, okay? You have the Pfizer BioNTech, which is an mRNA. Oh, by the way, the AstraZeneca can be stored at 2 to 8 degrees. So it's a very hardy vaccine. So it's very good in our setting because it's just like our other vaccines that we use, which we keep in a normal fridge and we move around the country in little coolers. The Pfizer, which is an mRNA is a lot more unstable. So you have to keep it at a much cooler temperature. It has to be frozen. And it's better kept at down at the levels of -80, although there's a recent study saying it can be kept for 2 weeks at -30. It is supposedly one of the more efficacious, as you know, it's one of the more effective. Up to 95% of people have a across-the-board protective response. And we're going to talk a little bit more about that in a little bit. The Sinovac is the inactivated vaccine, Chinese, again, somewhere around 70% efficacy. Sputnik 5, again, very similar to AstraZeneca, it's just using a different viral envelope. The Moderna is very similar to the Pfizer, mRNA. The Johnson & Johnson, that's the Janssen vaccine, uses, again, it's very similar to the AstraZeneca and the Sputniks, using a coronavirus itself, a cold virus, to deliver the genetic material to develop the spike protein. In terms of their pricing, was that the AstraZeneca is the cheapest one, right? This is herd immunity. And what I was saying was that for a population to be protected, we need to get a certain percentage of that critical mass, which tends to be about 2/3 of the population, 67 or so % of the population should be immune. And then the virus will stop transmitting in that population. That's what they call herd immunity. And you can get it through natural immunity or vaccination. Natural immunity to this virus is an unacceptable cost in terms of human life because of the amount of people that would have to die for us to get. Yeah? Hello? Yeah. This slide, I was just showing this slide to show how we develop an immune response and how the vaccine works and then continues to work. So what happens is that when you get exposed to an antigen, which is that little golden sun-like thing, it presents itself, it gets engulfed by some of your white cells called macrophages, gets presented to a particular type of immune cell, which then causes activation of B and T cells. And then these B and T cells are directed to form antibodies or specific responses to that exact antigen, or as we call it in this case, a bacterium, which is a bacteria, or in our case, it would be a virus, okay? So it becomes a very specific response, which is far more effective at eliminating that virus. What also happens is you get memory, so that you no longer have to go through this longer process of designing, because you've already designed and you have that design in memory. So if you get exposed to this antigen virus again, you immediately will crank out your response to kill that virus, okay? In this case, the vaccine is to the spike protein, not to virus itself. So as soon as the virus comes in, displaying its spike protein, we'll immediately crank out our response, yeah? So looking at vaccine hesitancy, okay? A survey was done in June 2020. And what it showed is that overall 71% or so of people said they would take the vaccine, all right? That was a question was asked, would you take a proven safe and effective vaccine for COVID-19? 71% of people said yes. And interestingly, you can see the variation by country. China, almost 90%, Russia, 55%. So depending on people's governance systems, you will also get variation in how a population will accept the vaccine or not. And clearly that's important to us because we need to look at our relationship with our governance, our government, and the governance systems, and with our health authorities in terms of deciding why people would be hesitant to taking a vaccine. US data, in October 2020, the US public, back in October, 69% of them said, yeah, they would. That's mid-August, sorry. Early October, it had dropped to 58%. And in Blacks, it had dropped from 65% to 43%. This is the impact of conspiracy theories, social media, and the negativity to the anti-vaxxer program or campaign, which caused people between August and October to actually drop their desire or their willingness to take a vaccine. When they asked nurses in the United States, list your concerns, and they're both negative and positive concerns. And this top one is top one across the world for all populations. It's happening too quickly. How can they develop a vaccine so fast? Normally it takes 10 years. How come they're developing it so fast, right? People don't have enough information. People are skeptical about the clinical trials process. People are skeptical about the vaccine approval process. They believe these things are corrupted by big pharma and by corrupt politicians and corrupt doctors. And there's that rhetoric is pumped out there very effectively. Again, back to vaccine development. Some people have personal or religious reservations, and that's just based on that ethos of that particular religion. I mean, in our context, it might be Rastafarians who are resistant to vaccination traditionally. Then, of course, you have interestingly, a minority of people felt that this thing was happening too slowly. Right? Now, we did the same thing with the St. Lucia doctors. Medical and Dental Association did a survey, I think back in February or January, I think it was. And 72% of doctors said yes, they would. And then you see the other 7% no, 11% maybe. What were their reasons? Some said they're going to wait it out to see how it plays out. Some said they have insufficient information on interactions, especially with medications that they may be taking or their patients may be taking. And then more information, more research. They don't trust it's going to be effective. They're not, and similarly, not sure it fully protects or for how long. And then the big one, worried about long-term side effects. The general public has said this as well. Will the vaccine affect my DNA? This vaccine development was too fast. I'm worried about side effects. So let us try and talk a little bit about that. First of all, has this vaccine been developed too quickly? The answer to that is no. Why? These vaccines have been in development for the better part of 10 years. Also, these vaccines are being developed in the context of really far more advanced genetic or molecular science, genetic engineering. Because by the time we sequenced the genome at the turn of the century, about 20 years ago, we then learned how we could reproduce any part of the gene, and also we could therefore reproduce or program proteins to be produced by any cell. Because once we had genetic material, we could put that into a cell and cause that cell to produce whatever protein we wanted, whatever protein we were coding for. And because we were now precise in our genetic information, we knew we could do this thing with precision. All right. You may have heard Obama talk about precision medicine, genomic medicine, precision medicine. Now, it frightens people, I understand. But the truth is there's not much to be frightened about. Just understand it, and then you can get comfort from that scientific understanding. So this technology and these new viruses, new vaccines were being developed within that context. Now, prior to SARS-CoV-2, prior to COVID-19, let's take the AztraZeneca. That vaccine was actually in development for Zika, chikungunya, right, and even Ebola. So they had already been working on the envelope and how that envelope can be used to deliver the genetic material. So now, when the Chinese in January gave the world the genetic sequence of the original SARS-CoV-2, it was very simple for us to say, well, we characterize the virus, we know the spike protein, we know how it interfaces, we know the genetic sequencing that produces the spike protein, we can replicate that sequence, develop it into mRNA or DNA, put that into an envelope that we've already developed, and deliver it. So it was really, as you can see, it wasn't rocket science at that point in time because the technology was already there for us to do it, you know? The mRNA vaccines, by the way, now, the mRNA is messenger RNA. Messenger RNA is how the cell gives instructions to the protein making apparatus of the cell. So what happens in normally, our DNA will translate its sequence into mRNA, which will then tell it's messenger RNA. It does just that. It gives a message to the protein making machinery of the cell, produce this protein based on this design and this genetic information. And it does that. The beautiful thing about mRNA is it disappears immediately. It gives its message and it dies. It just degrades. mRNA is designed to do that. And you could understand, we cannot have our cells constantly producing protein after protein after protein. So that is why the messenger RNA disappears quickly to stop the message. So in other words, cause the protein to develop and then back off. That's because otherwise our cells will be just overworked, overproducing proteins that we don't require. So similarly, when the mRNA for the spike protein is put into our bodies, it gives an immediate message and then it disappears, which is why those vaccines are in fact quite safe. Similarly, as I mentioned for the AztraZeneca, when it has produced the spike protein in the cell, that cell is eliminated by the immune system. So the DNA does not stay with us. It does not get incorporated into our DNA. It comes and it does what it does, gives the instructions and leaves, and it's gone. It's eliminated from our bodies. Okay. The side effects. The side effects, I can tell you from having taken the vaccine and seen my staff who took it, I can support exactly what the people are saying. Fever. When you take the AztraZeneca vaccine, fever, headache, body pain, nausea, dizziness, right? And it seems like the younger people with stronger immune responses tend to have more symptoms than us older people, right? I had a little bit, but a couple of Panadols, I was fine. So 24 hours is usually how long it lasts, and then you get better, okay? The second dose, reading the literature, the second dose is, the side effects are much less. I wasn't sure about that because I heard conflicting reports, but one of my doctor friends sent me the full sheet on AztraZeneca for health professionals, and it's very clear that the second dose, people are reporting less side effects with that second dose. Long-term side effects. In the phase 3 trials, there were 2 cases of transverse myelitis, which is an inflammation of the spinal cord, right? The people did recover from it, but they did have that transverse myelitis. However, the control group also had one person who had the same transverse myelitis. Transverse myelitis does occur in the human population to a certain extent. So it was hard to be sure that it was truly related to the vaccine, but maybe it was. So there might be some long-term neurological effects. Some people are saying that maybe the ringing in the ears, or even some people are saying some change in hearing might happen. However, what we are finding out is that it would appear to be minimal, really minimal, to the point of being negligible. And the other thing, when you're looking at side effects of vaccines, you have to compare it with what you're trying to protect from. So we're trying to protect from COVID-19. And the effects of COVID-19 are 10,000-fold what the side effect of any of these minor side effects of the vaccine would be. So when I make the decision, for instance, a risk and benefit decision, I decide to take the vaccine because I don't want to take COVID-19. I prefer the vaccine because it's going to be far better for me than the COVID-19. Because I remember, I said, it's unpredictable. I have no idea what COVID-19 would do to me in my body, right? And neither do you know what it'll do to you. So I'm not willing to take that risk, right? And the vaccine will protect from that. And And this is how the vaccine protects. The AztraZeneca vaccine, the studies right now are showing the first shot, 76% protection against symptomatic infections, right? 67% reduction of transmission of disease. So 67% of people do not, after this vaccine, do not transmit the virus. And 100% protection from severe disease, hospitalization, and death. It's also active against the variants, right? Maybe it may be less so in terms of the symptomatic infections or the reduced transmission of disease, but definitely when it looks like for severe disease, hospitalization, and death, it seems to be holding up at 100% protection against that. And that, to me, is what we would call the bottom line. Because if we can stop people going into hospital, we can stop severe disease, and we can stop death, that's the major win right there. And the other two, reduced transmission is beautiful, and of course, no symptomatic infections is also beautiful, but those are added on benefits. That's my view anyway. And I think recently somebody just sent me a couple of papers from the BBC this morning, pointing out in the UK, they are showing as they call it, the spectacular effects of these vaccines now. UK has done about a quarter of its population so far, right? And about 150 million people worldwide have been given these vaccines, and the side effects are really minimal at this point. I mentioned the acute ones. Yes, people get that, but nothing severe and nothing long-term as far as we can tell. Yes, it's too early to know for the serious long-term, and that's fine, but we are in a crisis right now. We will not answer some of those questions until later, but we need to move now. And that's where you need to take that risk management approach I spoke about. Second shot, people are saying delay the second shot of AztraZeneca to anywhere between 8 or even better 12 weeks, because that boosts its efficacy up to 82%, whereas the original recommendation of 4 weeks is not as efficacious. Okay. And the St. Lucia rollout. You guys still with me, right?
Yes, we are.
Oh, great.
Yes, we are.
Okay, great. The St. Lucia rollout. St. Lucia has identified 79% of our population is over the age of 18, and this is our target population. That's 144,405 people. The vaccine supply the government has been able to secure is 185,000 doses from directly from India, 74,000 from COVAX, 35,000 from CARICOM, and 3,000 that we have in hand from Barbados and Dominica. That's a total of 297,000 vaccine doses, which you would appreciate is enough to meet our target population. Of course, it's going to be coming in a phased way. And that phasing is based on supply, so manufacturing and demand. So it's a little unpredictable, but we would hope that we can do this within 6 to 8 weeks to have the complete supply in. Regardless of that, the government has come up with a phased vaccination approach. Phase 1A is high-risk workers, and that's what they're doing now. Phase 1B is all vulnerable people, and which is people over 65 and people with chronic non-communicable diseases, right? And that is not 65, over 65 plus, but it's 65 and people with non-communicable disease. That's about, I think the population, that's about 36,000 people. Then the phase 2 is borderline correctional facility and the rest of the frontline workers, which would include supermarket workers, hotel workers, and so on. And then phase 3 is the rest of the population. If we can collapse this down, I think we should. And if we can expedite it, so we should. And we have plans, we have proposed ways in which this could be done. One of the ways we've proposed is that government should use their polling stations, of which there are 129. Government should use its enumeration maps, which are linked to polling stations, and the list of residents as per polling stations, because that covers most of the people over the age of 18. And those enumeration maps are very detailed. They even have walking paths, so you can know how to get to every house on walking a particular trail. And the maps are in bites of 100 households. So we could deploy teams to vaccinate in polling stations, as well as teams to go out and go to houses for people who did not present themselves to the polling station. Also, we're looking at an app that we're hoping government will take up, an iVax app, which would also allow us to know who has been vaccinated and indeed where and when. Because you can also appreciate that we need to bring faith-based organizations on so churches can vaccinate. We need to bring, this is my view, and this is not the government's plan. This is what I'm thinking and what I'm proposing to you. We can bring on employers so we can vaccinate in workplaces. So I just think we should have an all-out approach. We may have to hire 1,000 or so people to be the gophers to move around. We may even have to bring on private people who can vaccinate, both nurses, doctors, and others who can actually do the vaccinations to help us I think, to do this thing as quickly as possible. But for me, we should get to this as fast as we can. We are small. We have good reach through these various mechanisms that we have, especially that electoral mechanism to get to every household. And that's probably what we should do. So that's my last slide, which says that essentially this thing is all about disease control or public health control. We spoke about containment, which is quarantining and isolating through case identification and contact tracing. And you can add to that mass testing. Mitigation in terms of what we need to do, like physical distancing and masking. Then we talk about herd immunity, which is, we think vaccination is the way to go. And then the main underlying forces for control are social, legal, and both of these are fueled by education. So for me, I prefer social controls. I think they're far more effective, far more nuanced, far more finessed. However, it takes a lot more education and a lot more one-on-one communication with people to get good social control. But when you do get good social control by having all of your people on board with you, it's amazing. And it has multiple benefits because you've now empowered every single person to be part of the solution, and that augurs well for a whole host of things: their mental health, their social health, their identity, their feeling of belonging. All of these things, I think, are crucial factors in us tackling this COVID-19. I must say that I think solutions, regardless of what everybody says, I think solutions have done an amazing job. I think solutions truly try. I go up and down the country. Yes, I see people without their masks, but I see many more people with their masks and genuinely trying. And I think we should hold hands with them and encourage rather than police and warden and use legal criminal type approaches, criminalizing type approaches for behavior control. I don't think in a disease like this, that is the best strategy. Thank you.
Thank you, Doc. Can I ask you a question? Is there any way you can share that presentation? I mean, you make a valid point, and we have been discussing it among us. But the educational part for the society, and one of the approaches maybe each employer go to their staff and start explaining, what it is and why they should take it, and then you will increase the percentage of people willing to take it. So I believe your material is very helpful. That's my personal opinion, but it's very helpful for example, for me to go and tell my employees, listen, try to summarize all what you told us without obviously the technical part. And then try to, educate people to take the vaccine. So it will be very helpful if you can share that with us.
Yes, and I think that's why I was asking Faye to make sure and do the recording so each one of us can get a copy of this recording so we can replay it in the portions that we want or in its totality if we so desire. Also, one of the reasons I went down to the financial center to take my vaccine was I wanted to get an opportunity to give a brief message. And I did get one out, which is a short video, which is like a 2-minute video, which I'm more than happy to share. Government did it, not me. Government did it. But it makes the point about how much protection this vaccine gives you. And I think if you want one single injection of something, that video probably gives that injection. I noticed a lot of people are giving me good feedback on it. So it seems to hit the mark. So, I mean, that can be shared. I think Orlando probably has it as well. That can be shared with everybody as well.
I got that video and we share it. But I think we have a little bit more information in this slides you present. And then basically we can customize our own explanation to our employees, our friends, all the people skeptical around us.
Exactly. Because I think, you see, this is part of what I talk about, why each and every one of us must be empowered with the information and then must be empowered to share it. Because this is not a doctor's thing or a ministry thing. This is a people thing. And it's a people's response that's required. And that's why the more we share the information, a lot of people tell me don't share all the some of the technical stuff. But for me, I think it's important that people see some of the technical stuff, because it's patronizing of me to think that, oh, people can't understand it. I mean, you can't understand that. Of course, people can understand. And they should be given that opportunity to digest, I think, some of the more technical information so they can have a better understanding. Because once people understand about the virus and what it does and the vaccines and how they work, I think the more likely they are to say, yeah, that's making a lot of sense to me. I feel comfortable making this decision.
Agree.
All right, so thank you very much, Dr. King. At this point, does anybody have any questions they wish to ask?
I just want to say thank you to Doc for giving us, this opportunity to understand a little bit more. Certainly, you answered some of our questions, which we can the same way transmit to those people. But on my side, thank you very much.
You're welcome.
All right, well, apparently Dr. King has done an excellent job of delivering because no one has any questions. So the recording will be sent to everybody. Chef Orlando, are you there?
No, I think he had to leave.
Oh,
he had to leave because I know he has an engagement before midday.
I'm away, no problem. Okay, so the recording will be forwarded, like I said. So thank you again, Dr. King, and thanks for everybody in attendance. I hope this has helped in allowing everyone to have a better understanding of the vaccine.
Thank you.
Thank you.
Have a good day.
You too.
And thanks for attending.